We had studied the brachial plexus and had come up to the trunk and the branches. Now we will study the nerve supply of the upper limb. You know that the lateral cord continues as the musculocutaneous, the medial cord as the ulnar, and both from the medial and lateral cord arise the median, and from the posterior cord that continues as the radial. So we will study the course, the branches, the testing, and the treatment of the paralysis of these nerves. The musculocutaneous, starts on the lateral side of the artery as a continuation of the lateral cord. It pierces the coracobrachialis muscle, which pierces it and supplies it. Then it lies between the biceps and the brachialis, supplying both, and it emerges on the lateral border of the brachialis between the biceps and brachialis on the medial side and the brachioradialis muscle on the lateral side. It then pierces the fascia of the forearm and becomes the lateral cutaneous nerve of forearm. Now this nerve is usually paralyzed in Erb's palsy, and we'll label these muscles for you. This is coracobrachialis, this is biceps, this is brachialis, and this is brachioradialis. And this is the deep fascia of the forearm. So this is the course of the nerve, and if it is paralyzed, the major thing is that because of the paralysis of the biceps, flexion of the elbow, because of biceps and brachialis, and supination of the forearm because of biceps, is lost, even though supinator is present. So, one thing that we can do to substitute the paralysis of the brachioradialis, which has occurred somewhere here on the upper trunk, the axons will have to travel a very long distance to supply the brachialis and the biceps. So this is the ulnar nerve, and from both the lateral and the medial cord is the median nerve. So these thick nerves, we can borrow a section of these nerves and attach it to the myoneural junction of the brachialis and the biceps. So we can take this section and we can put it at this myoneural junction after sectioning the musculocutaneous branches to these nerves. So now the axons will have to travel a very little distance to innervate these muscles, and this operation is called as the Oberlein's operation. Of course, if 9 months have passed and the patient is reporting after 9 months of Erb's palsy, and then the paralysis is residual, then you can substitute the biceps, because this is the coracoid, suprascapular notch, and here will be the glenoid. And this coracoid gives rise to 3 muscles: the pectoralis minor going medially, and the coracobrachialis, and the short head of biceps going laterally. So this is the short head of biceps, and it has caused one head of the biceps. The long head has come from the bicipital groove. This is called the second head of the biceps. And here you will have the biceps muscle. So you can simply take this pectoralis minor, cut it off its costal insertion, and reroute it and stitch it to the biceps. So pectoralis minor to biceps will restore biceps and restore both flexion of elbow and supination of the forearm. So this is about the musculocutaneous nerve. Now we move on to the median nerve. The median nerve arises as a from 2 roots, from the lateral cord and the medial cord, lies on the lateral side of the artery, till middle of arm. Then it comes to the medial side. So here is the artery. Here is the lateral and the medial cord. Here is the formation of the median nerve. It's lying on the lateral side of the artery till middle of the arm. Then it crosses and comes on the medial side. Now this artery would divide after crossing the elbow into radial and medial. Here will be the medial epicondyle, and from the medial epicondyle there will be the trochlea. There will be the trochlea here. And the capitulum on this side. Here will be your coronoid process of the ulna, and here will be the radius. So the pronator teres muscle will arise from the medial epicondyle, and the artery will pass behind it. artery will pass behind the ulnar head. So you see the median nerve coming on the medial side of the artery faces the humeral head of the pronator teres and the ulnar head of the pronator teres, passes in between them. The ulnar nerve crosses the artery from lateral to medial, lying behind or deep to the ulnar head of the pronator teres. Now this is an extremely important relation because when you are trying to release the pronator teres in chronic VIC, you have to first deal with the humeral head, then save the nerve, and then deal with the ulnar head of the pronator teres and save the artery. After passing between the two heads of the pronator teres, it dips posterior to the flexor digitorum superficialis because that also originates from the supinator crest of the radius and has a humero-ulnar origin also. And then it comes to lie between the flexor pollicis longus, which is on the radius, and flexor digitorum profundus, which is on the ulna. So this, I am making the flexor digitorum superficialis arising from the supinator crest of the radius and having a humero-ulnar head also, and the nerve is lying deep to the flexor digitorum superficialis. Between the flexor digitorum pollicis longus on the radial side and flexor digitorum profundus on the ulnar side. Now, here the nerve is accompanied by the anterior intraosseous branch of the ulnar artery, which is an end artery. In vascular insufficiency, because of this end artery, the adjacent areas of the flexor pollicis longus and digitorum profundus undergo necrobiosis, causing the chronic VIC. 5 centimeters above the wrist, you have seen the palmar carpal branch arise, which will supply the thinner skin. Then the nerve passes between the flexor carpi radialis and palmaris longus tendon deep to the carpal ligament in the carpal tunnel. This divides into superficial and deep branch. The superficial branch goes on to supply the first, second and third web space, and thus 3.5 fingers, the second and the third web space. So the 3.5 fingers, and communicates with the superficial branch of the ulnar nerve. So 3.5 fingers, superficial nerve, and communicates with the superficial branch of the ulnar nerve. Now, we make the course of the deep nerve in the hand. So the section of the hand, first, second, third, fourth and fifth metacarpal section, placing of the dorsal intraossei and palmar intraossei, placing of the transverse head of adductor pollicis, Placing of the opponent's flexor and abductor of the pollex and opponent's flexor and abductor of the digiti minimi. Placing of the palmar aponeurosis and the medial septum. Placing of the flexor pollicis longus, flexor digitorum superficialis and flexor digitorum profundus tendon. Placing of the lumbricals from the FDP to the extensor expansion. And then after this we pass the nerve. So the median nerve, deep branch, abductor and flexor pollicis brevis, pierces the opponents and supplies the first and second lumbrical. Lies between flexor and abductor, pierces the opponents and supplies the first and second lumbricals. Right? So revise the course. The median nerve arises on the lateral side of the artery from the roots, from lateral and medial cord having two roots, goes up to the middle of the arm, crosses the artery, becomes medial to it, passes the elbow, lies between the two heads of the pronator teres, separated from the ulnar artery by the ulnar head of the pronator teres, crosses the artery, dips under the radial and the humero-ulnar origins of the flexor digitorum superficialis, lies between flexor pollicis longus and flexor digitorum profundus, accompanied by a median artery, branch of the ulnar nerve, also called the intraosseous artery. It's an end artery, and therefore in ischemia there is an elliptical necrobiosis of the flexor digitorum profundus and flexor pollicis longus muscle in chronic VIC, because this is the only supply and it's an end artery. Then 5 centimeters above the wrist it gives a palmar carpal branch supplying the thinner skin, passes in the carpal tunnel between palmaris longus and flexor carpi radialis, divides into superficial and deep branch. The superficial branch supplies 3.5 fingers on the radial side and communicates with the superficial branch of ulnar. The deep branch passes between flexor and abductor pollicis brevis, both are brevis, pierces the opponent's pollicis, supplies the first and the second lumbricals. Now if you test this nerve, then testing means one is
so now testing the median nerve,
and the second,
the median nerve supplies all the forearm muscles except the flexor digitorum profundus,
all forearm flexors
of the third and the fourth
digitorum profundus,
third,
the
IP joint
and
the third and the fourth finger are not flexed by the median.
Because of this paralysis,
then the flexor carpi ulnaris, palmar flexion
pointing,
not the median. All the flexor digitorum superficialis
folded inside,
and the first and the second FDP are supplied by the median.
The index finger will be pointing because the flexor digitorum
paralysis
profundus
of the FDS and FDP 1 and 2
for this.
The person, when you ask him to clasp the hand,
these two fingers and a slip from the ring to the middle finger would also
FDP of the little and the big finger will be able to flex these two.
And
since there is a digital communication between the FD
and
P of
it is positive for
ring and the middle finger will also.
Now the other thing is that
but
it
the
supplies
index
the
finger
abductor
will be
pollicis
pointing.
brevis.
And
And
this
therefore,
is called as the pointing index test.
the thumb
And it is present when the median nerve is involved
will
around
not
the
be
elbow.
able to abduct. So
The
this
second
is called
involvement
as
of the median nerve is in the carpal tunnel.
pen
That
test.
causes
Put a pen
neuralgia
here,
in 3.5
the thumb
fingers
will not be able to abduct.
and
So
can
this
be
is the pen.
decompressed by either a
Okay.
depomedrol
It is called
injection
as
or
pen test.
division of the
So
carpal
pen test
ligament.
positive in high and low,
Palmar
but
carpal
pointing index
ligament
positive only in high paralysis
and
of
opening up of the carpal
median nerve.
canal.
The major thing to
If there is a
reconstruct in
leprosy
median
and the
nerve
nerve gets
in
thickened
residual
and gets
paralysis,
paralyzed,
all
then
the other
main
things
movement to
stay
go
the same.
is opponents.
Splint in
Opponents,
functional
normally
position
the thumb would lie
and
perpendicular
maintain
to
muscle
the
tone
axis of
by,
the fingers.
by
So the
galvanic,
flexion of the
by
finger,
Faradic,
this
by
is the
active
flexion of the
assisted,
thumb
by
at
active
90
and by
But if we rotate the
active resisted
metacarpal,
exercises.
then the
All
thumb
the things
movement
are same
starts opposing the fingers.
except the residual
Therefore, this
paralysis
rotation of the
where you have
metacarpal,
to
rotation of the
reconstruct
metacarpal
the
is called as opponents. It occurs at the
opponent's
carpometacarpal
pollicis.
joints. So median nerve paralyzes this
So you
opponents,
want this
and it's extremely
metatarsal
important to
to
restore
rotate
this
like
opponent.
this so that
For
when
this
it comes
opponents,
here,
you need
its movements will oppose the
adequate web
movement of
space.
fingers.
You
So
need a
this
stable
action
carpometacarpal joint
of rotation of
and a painless
metacarpal
carpometacarpal joint.
is
These are
performed
the
by the
prerequisites of
opponent's muscle.
opponent's
Performed
plasty.
by the
And basically,
opponent's
you
muscle,
take the flexor
which
digitorum
rotates this
superficialis
metacarpal.
tendon of the ring finger,
Now,
withdraw it from the wrist,
this
pass it around the
opponent's,
pisiform,
for
and
this
attach
opponent's,
it to the
it
abductor
occurs in the
pollicis
carpo
brevis insertion on the thumb, equidistant from the flexion
metacarpal
extension
joint
axis.
of the
So this tendon passing
of
like
the
this
first
will be able to pull the metacarpal into
metacarpal.
rotation. So that operation
This
is called
is
as
joint which
opponent's
must be
plasty.
painless and
And this
stable.
particular opponent's plasty goes by the name of Brand's opponent's plasty.
And secondly, there must be a lot of space to allow this movement to occur. So the first web space must be adequate. So after ensuring this, you will do an opponent's plasty, and for opponent's plasty, you use the flexor digitorum superficialis tendon of normally the plane of the thumb is perpendicular to the plane of movement of fingers. Therefore, if the flexion of the thumb is in this plane, then the flexion of the fingers would be in this plane. But if this metacarpal rotates, then the flexion of the thumb will oppose the flexion of the fingers. Thus, this rotation of the metacarpal on the carpometacarpal joint, this rotation of the metacarpal is referred to as opponents. It is primarily produced by the abductor pollicis brevis. So, median nerve paralysis basically causes a loss of this movement, and therefore the pinch and the grasp movement of the hand, function of the hand, are affected. So to restore opponents, you need a wide web space, no adduction contracture of the web space, and you need a painless carpometacarpal joint and a stable carpometacarpal joint, because it is on the carpometacarpal joint that this rotational movement will occur. Now, to give power to the paralyzed abductor pollicis brevis, you take off the FDS third from its insertion on the middle phalanx base of the ring finger. You withdraw it into the forearm, you turn it around the pisiform bone, and you put its two slips
With onto the insertion of the abductor pollicis brevis, equidistance from the flexion extension axis of the, so this insertion here and here is equidistant from the flexion extension axis of the thumb, so that now the tendon will not produce flexion extension but will produce only rotation. This operation is called as Brand's opponentsplasty. There are many opponentsplasty, but let us leave it to the postgraduates. But this is one that the undergraduates can. With the ulnar nerve, the ulnar nerve starts as a continuation of the medial cord, from which are also arising the medial cutaneous nerve of arm and forearm and the median root of median. So this is the ulnar nerve. It continues on the medial side of the artery till the middle of the, this is the head, this is the greater tuberosity. Here you have the medial epicondyle, the trochlea, the capitellum and the lateral epicondyle. So the nerve, there is this medial intermuscular septum, and here is the lateral intermuscular septum. The artery is here. And the nerve is lying on its medial side, and it pierces the medial intermuscular septum and becomes posterior to it till it reaches the medial epicondyle and passes behind the medial epicondyle. We look on the medial epicondyle from the medial side, and this is what you see about the medial epicondyle. Then you can see the trochlea, and then you can see the olecranon and the coronoid processes, so that you can see the ulna here. And then you place the posterior part of the ulnar collateral ligament connecting the medial epicondyle and the olecranon, and you make a muscle which arises from medial epicondyle, the posterior part of ulnar collateral ligament, upper 1/4 of posterior border of ulna, and this muscle we'll call as flexor carpi ulnaris. And then from the surface of the ulna itself, you have a muscle which is the flexor digitorum profundus. So here is the flexor digitorum profundus. We made it dotted. So the ulnar nerve passing behind the medial epicondyle passes under the flexor posterior part of ulnar collateral ligament, and then comes to lie deep to the flexor carpi ulnaris, and then between the flexor carpi ulnaris and flexor digitorum profundus. So it supplies the flexor carpi ulnaris and it supplies the flexor digitorum profundus, the medial two parts, that means the third and the fourth part of FDP. Then the nerve passes, this is the little finger, this is the middle finger, ring finger, this is the middle finger, this is the index finger. Here you have the thumb, and here you have a bone which is called as the pisiform bone. Everybody can feel it. Now the flexor carpi ulnaris is converted into a tendon and is inserted into the pisiform bone. Here is a hook, which is the hook of the hamate, and this flexor carpi ulnaris has also sent a slip which is called as the pisiohamate ligament. Now, the nerve traveling medial to the pisiform, the flexor carpi ulnaris, medial to the pisiform, divides into a superficial branch which supplies the 1.5 ulnar side fingers and communicates with the superficial branch of the median nerve. The deep branch passes under the physiohamate ligament and comes to lie across the hypothenar eminence. Now we'll make the 1, 2, 3, 4, 5. We'll place the dorsal interossei in all 4 web spaces, but palmar interossei only in the ulnar 3. We'll place the opponens flexor and abductor of the pollex, opponens flexor and abductor of digiti minimi. We will place the transverse head of adductor pollicis. We will place the palmar aponeurosis, and we will place the intermediate septum. We place the flexor pollicis longus tendon, the 4 tendons of flexor digitorum superficialis, the 4 tendons of flexor digitorum profundus. We will place the extensor expansions on all 4 fingers, and we'll place the lumbricals coming into those extensor expansions from flexor digitorum profundus tendons. Now, after this, the deep branch is lying between flexor and abductor digiti minimi, pierces the opponents, supplies the 3rd and 4th lumbricals, all interossei, and ends in transverse head of adductor pollicis. So the ulnar nerve. The first muscle to be supplied is the flexor carpi ulnaris. And so you see wasting of the flexor carpi ulnaris on the side. And then palmar flexion ulnar deviation is affected. The second thing to be supplied by the ulnar nerve is the 3rd and the 4th components of the flexor digitorum profundus. These 3rd and 4th component would produce flexion at the distal interphalangeal joints, which will be lost in high ulnar nerve paralysis. At high ulnar nerve paralysis means where the nerve is passing through the behind the posterior part of ulnar collateral ligament or the canal of Cannon. So in this, the flexor carpi ulnaris and the flexor digitorum profundus 3/4 will get paralyzed. Now 5 centimeters above the wrist, it will give a palmar carpal branch which will supply the hypothenar eminence skin and the palmaris brevis. Then it will pass through under the physiohamate ligament, and as it passes under the physiohamate ligament, before it will divide into a superficial branch which will go into this web space, supply the 4th and the 5th finger and the little finger, so which makes 1.5 finger, and communicate with the superficial branch of the median nerve. The deep branch will pass under the physiohamate ligament and is subject to compression here, will pass between the abductor and flexor digiti minimi, pierce the opponents, supply the 3rd and the 4th lumbricals, supply all interossei, and end in transverse head of adductor pollicis. So, the hypothenar muscles will show wasting. The abductor digiti minimi will get paralyzed. So you do this, and this is called as the Guava's test. Then the third, fourth lumbrical will get paralyzed. Their function is that they flex the MP joint and extend the DIP joint. So now the reverse of this, extension of the MP joint and flexion of the PIP and DIP joint. So this will form what is called as the ulnar claw hand. Now in case the paralysis is high, the flexor digitorum profundus of third and fourth will be paralyzed, and therefore the distal interphalangeal joint will not be able to flex, and the clawing will, instead of this, the clawing will decrease. So normally a higher paralysis should lead to a greater deformity, but here the higher paralysis is lessening the clawing, therefore this is called as ulnar paradox. So after the lumbrical 3 and 4, it supplies all interossei, and that means that pad dab. Pad means palmar interossei adductors. So you place a card between the adductors and you try to pull it. If you can pull it easily, the card test is positive and it signifies paralysis of palmar interossei. Then you hold a book like this, and this is the adduction of the thumb. Now if the adductor pollicis is paralyzed, he will use the flexor pollicis longus instead of the adductor pollicis. This is the Froment sign positive, and it signifies the paralysis of the adductor pollicis. So signs of paralysis of the ulnar nerve are flexor carpi ulnaris wasting, palmar flexion ulnar deviation of the wrist gone, palmar carpal branch, that means hypothenar anesthesia, then 1.5 finger sensation gone, then abductor digiti minimi paralysis Guava's test positive, then ulnar claw hand, which decreases in a high paralysis because FDP cannot flex the distal interphalangeal joint, then card test for palmar interossei, and Froment sign or book test for adductor pollicis brevis. And this canal of Cannon is medial epicondyle, trochlea, olecranon coronoid, posterior part of ulnar collateral ligament. And if this ulnar nerve gets thickened here, thickened by leprosy, so it's thickened, then it gets compressed and entrapped. What you have to do, you have to remove the posterior part of ulnar collateral ligament or do a medial epicondylectomy so that the ulnar nerve is decompressed and it never gets involved. So decompression of the canal of Cannon and here is the pisiform, here is the hook of hamate, here is the pisiohamate ligament, here is the insertion of flexor carpi ulnaris, and we told you that the deep part of the nerve passes under the pisiohamate ligament. Detach the pisiohamate ligament from the pisiform and you have decompressed the canal of Guyan. So first step is decompress, change the DDS to clofazamine in leprosy because that will not produce swelling of the nerve, add steroid. So this will treat or prevent the ulnar nerve involvement. Then you wait for recovery, and then you want to prevent contracture, you splint in intrinsic plus position. The claw hand is the intrinsic minus, this is the intrinsic plus position. MP joint flexion, PIP, DIP extension is the action of lumbrical, and that is the intrinsic plus position. You sprint fingers in intrinsic plus position to prevent contracture, and then you keep on stimulating the the muscles which are paralyzed, waiting for recovery. And you do it by galvanism, Faradism, and active exercises, which means assisted, nothing, and resisted. So after that 9 months have passed and there is no recovery, you want to restore lumbrical power by FDS of flexor digitorum superficialis of, there is a thumb, so FDS of second. FDS of second. Take this FDS out, convert the FDS into 4 slips, pass them these slips through the lumbrical canal and attach them to the extensor expansion. So FDS through the lumbrical canals, and you stitch them to the extensor expansion in intrinsic plus position. The operation is called as Bunnell's operation. The second thing that you can do is that you are looking at the 4 fingers, and here is the of a dot. Here is the adductor pollicis. You take the extensor indices. These are the 4 extensor digitorum, and this is the extensor digiti minimi. Take this extensor indices, pass it through this interosseous space, and attach it to the adductor pollicis. So this is the tendon transfer for the ulnar nerve. For the radial nerve, here is the glenoid, the supraglenoid tubercle, the coracoid process, the suprascapular notch, the upper border of the scapula, the medial border of the scapula, and the lateral border of the scapula. Here you have the head of the humerus, the greater tuberosity, and the shaft. And here the shaft goes down and gets into the lateral epicondyle, capitellum, trochlea, medial epicondyle. So this is the humerus. Then we attach the radius here and the ulna here. Here is the lower end of the radius, and here is the lower end of the ulna. Here are 4 proximal carpals, 4 distal carpals, the phalanges, all right. Then we place the lax part of the capsule. We place the bicipital groove, the lesser tuberosity. Then we place the subscapularis uppermost, the teres minor, the teres major attaching to the medial lip, the latissimus dorsi coming like this, latissimus dorsi coming like this, then we place the long head of triceps from the infraglenoid tubercle and create the quadrangular space, the lateral triangular space, and the medial triangular space. Medial triangular space. Then we place the artery here, and from the artery the posterior cord, first supplying the upper and lower subscapular, then supplying the latissimus dorsi, and then passing through the lateral triangular space as the radial nerve and giving a branch axillary through the quadrangular space, which supplies the teres minor, which supplies the deltoid muscle. Here is the deltoid, and which supplies the skin over the deltoid. So this nerve, axillary nerve, winds round the surgical neck of humerus, supplies the teres minor, supplies the deltoid, and supplies the skin over the regiment patch area. The radial nerve supplies the triceps. It passes through the lateral triangular space, accompanied by the profunda brachii artery. Profunda brachii artery lies in the radial groove, supplies also the lateral and the medial head of triceps, pierces the lateral intermuscular septum, lies between the biceps and the brachialis, same groove as the musculocutaneous, biceps and the brachioradialis, crosses the elbow, divides into a deep branch which winds round the neck of the radius, supplying the extensors of wrist, MP joints and thumb, along with brachioradialis. The superficial branch continues on the supinator crest, accompanied by the radial artery on the medial side. After the brachioradialis gets inserted here on the radial styloid, the nerve winds round it and supplies the dorsum of 3.5 fingers and palm. So this is the course of the radial nerve, and basically the paralysis of the radial nerve leads to wrist drop, finger drop and thumb drop. The specific muscle to be restored in wrist drop is extensor carpi radialis longus or brevis. Finger drop is extensor digitorum, and thumb drop is abductor pollicis longus. For ECRB, you need pronator teres. For extensor digitorum, you need flexor carpi ulnaris, and for abductor pollicis longus, you need palmaris longus. So this is the tendon transfer, and of course before the residual phase of paralysis, you splint to prevent contracture, and you try to maintain muscle tone by the combination of galvanism, Faradism, active assisted active and active exercises. So this is the radial